Thank you very much for the introduction. I'm very honored to be here. Thank you very much. Thank you. So, do I press here? Yes. So thank you very much, and I'm Gordon, and today I'll share with you some information and insights in mental health in people living with HIV. So there are three parts to my talk. The first part is people living with HIV and mental health problems. So people who do live with HIV, they do experience quite a few mental health problems. So people with HIV commonly have mental health problems, as I will talk about in a minute. And also, people who have mental health problems are at higher risk of acquiring HIV. So it's like a vicious cycle where people who have mental health problems, they get a higher risk of HIV, and then when they have HIV, they have a higher chance of mental health problems. So it's a cycle that doesn't seem to end. So as professionals, we have to do something to help these people who are experiencing challenges. And one of the challenges that people may experience is that LGBT people are often marginalized and often facing discrimination, and therefore that would in turn increase the risk of mental health problems as well. So it's like a perfect storm where all these factors, intersectionality, as Professor Lee has already mentioned, they really brood together and create a lot of mental health problems. So over time, over the spectrum of time, people who do have HIV, people who get infected with HIV, they may, at first, when they find out about the diagnosis, about the presence of virus in their body, they may experience adjustment problems, such as adjustment disorder due to newly diagnosed HIV infection. And over time, there could be a lot of anxiety, a lot of depression because of all these different stresses living with HIV. There may be like discrimination, marginalization. And over time, there could be shame, disgust, there may be self-stigma, and therefore people isolate themselves. They don't want to tell anyone about their HIV infection. They isolate themselves from friends, from family, and they may feel very guilty or having contracted the virus. And I will talk about that in a case I will share in a minute. And over time, some people, on the other hand, on the other end of the spectrum, some people may feel that they have to do something to make themselves healthy, make themselves as healthy as possible so that the virus doesn't affect their daily life. So they may do as much as possible to stay healthy. They may exercise a lot. They may eat very healthily. They may take a lot of supplements. And because they want to stay so healthy, they may have a lot of health anxiety when they have the most minor physical problem. When they have a headache, they think, oh, is it HIV? When they have an itch on the skin, oh, they think, oh, is it HIV? So that could be the other end of the spectrum. And so there can also be substance abuse, substance misuse, or chemsex, because some people may think that, oh, now that I have HIV, it doesn't matter anymore. I can have as much sex as possible. So that could also lead to other problems, like such as superinfection, and also substance misuse problems like psychosis. So that can also lead to many other problems. And over time, because HIV directly infects brain cells, there can be cognitive problems such as memory impairment, language impairment, attention problems, and I'll talk about these in a minute. So in psychiatry or in mental health in general, we often devote our time in depression and suicide because suicide is like the ultimate outcome that we want to prevent. And in people living with HIV, it is actually very common to have depression. So 30 to 50% of people do experience depression, a major depressive episode, sometime after HIV infection. So one third to a half of people with HIV experience depression, and that is very common. So we have to actively look for it. And suicide is a symptom, a behavioral manifestation of depression. So, and in people living with HIV, there is a 9 times increased risk of suicide. So that is also something we have to look for. The risk factors of suicide include younger age, because people who are younger, they're often more vulnerable. They may not have the psychological or material resources to cope with the diagnosis, to cope with the problems associated with HIV. There can psychiatric illness, as I said, is very closely linked to HIV infection. Social isolation because of self-stigma, stigma from the society, that also increases the risk of suicide, and also exposure to some antiviral and antiretroviral medication that also can increase the risk of suicide. So we have to bear that in mind. Apart from depression and suicide, there can be other mental health issues related to HIV as well. So one issue is mania. Mania is the opposite of depression. So a lot of people have a misunderstanding regarding mania. So in mania, in Chinese, 狂躁. And 狂躁, a lot of people think that 狂躁 is irritability, is the tendency to throw temper. But the medical definition of mania is actually had to have at least 4 days of sustained elated mood with a decreased need for sleep. And and irritability is only one symptom of mania. So we have to bear that in mind, the medical definition of mania in mind. So mania can occur as a part of HIV psychosis, or it can also be a side effect of a retroviral medication. So that is something to bear in mind as well. Another manifestation, mental health issue, is anxiety. So people who do live with HIV, they can experience a lot of different anxieties. Biologically, the anxiety could be a generalized anxiety disorder, meaning that the person is anxious like all day, every day, most of the time, like being anxious for no reason. There can be panic disorder, which is an intense bout of anxiety that seems to come out from nowhere, generally lasting about 20 minutes. There can be post-traumatic stress disorder and obsessive-compulsive disorder, and that is also classified as anxiety. For HIV infection, because the HIV virus affects basically the whole body, so there could be chronic pain as well, and studies suggest that 80% of people living with HIV experience chronic pain. And when you live with chronic pain, people just take medication to relieve the pain, and that can lead to that can be a risk factor for substance misuse. Another mental health issue that may manifest itself is delirium. Delirium is an acute confusional state, which is fluctuating. It fluctuates like from hours to days. So the manifestation of delirium can change within hours. So up to 30% of AIDS patients have delirium. So it is quite common as well. And this delirium, this acute confusional state, can be caused directly by the virus. It can be caused by secondary infections in the brain, that may be due to tumors or substance withdrawal when people take substances, such as alcohol or some other anxiety medication. If they stopped cold turkey, then that may cause withdrawals, which may cause delirium. And another issue is psychosis. So that can be a feature in early HIV-associated dementia. And also, that can also be caused by substance use as well. I remember a case where when I worked in the public hospital, there was this 21-year-old guy who was admitted for psychosis. So he lives with his family members and also the boyfriend in the same bedroom. So the family is very progressive. And So he was admitted to the hospital because of abnormal behavior, not sleeping, trashing the flat, and he was admitted to the hospital. And so it was known that the person, this 21-year-old guy, had HIV. So at that time, I thought it was HIV psychosis. And then I gave him medication to treat the psychosis, and then his symptoms quickly subsided over like a day or two. And then so I let him go, let him be discharged from the hospital, and then some days later, the urine toxicology results showed that there was amphetamine in the urine. So actually, it was chemsex causing the psychosis, but he didn't tell us at all. And because urine toxicology results takes quite a few days to arrive, like a week to arrive, so by the time the results arrived, he was already discharged. So that was quite a memorable case for me. So next, I would like to talk about HIV-associated neurocognitive disorder, which is also a manifestation of HIV. So HIV virus actually enters the central nervous system very, very soon after the first infection, after the primary infection, and then it stays in the brain. So the brain cells are directly infected, and it also causes neuronal loss. So that's why there is neurocognitive symptoms in HIV, people living with HIV. So it is actually quite common. So 30% of people who have HIV-associated neurocognitive disorder, these neurocognitive symptoms are the first complaint, the first presenting complaint. So they go to the doctor complaining of symptoms that are not, but that are very general, and it is actually the first symptom that is manifest in an HIV infection. So 30% of the people with HIV go to the doctor for the first time because of these neurocognitive symptoms. So it is quite a big proportion, and these symptoms are often very general, so it can be hard for the doctor to decide that these symptoms are actually caused by HIV. And then as time goes on, 70 to 80% of people living with HIV can develop some kind of a neurocognitive disorder, and at postmortem, 90% will have some changes in the brain. So it is quite a big issue. So when I say that 30% of the people first present with a neuropsychiatric symptom, neurocognitive symptom, so these symptoms include headache, altered peripheral sensation, leg weakness, and also seizures. So when someone goes to the doctor complaining of leg weakness or altered peripheral sensation, the doctor is not going to think about HIV as the first reason for these symptoms. And yet 30% of the people present to the doctor with these symptoms. 30% of the people living with HIV first present to the doctor with these symptoms. So I think this can be quite alarming as well. So as time progresses, there can be some neurocognitive symptoms such as cognitive slowing. They may think slower, they may be more forgetful, they may be more absent-minded, motor slowing, their actions may be slower as well. There can be poor coordination. They find that, they have tremors when they hold chopsticks, or they may, when they hold a glass of water, they may find themselves having tremors, the water shaking. So they may also visit a doctor for these symptoms, and the doctor is unlikely to come up with HIV as the first differential diagnosis. And because these HIV symptoms is hard to pick up, and therefore with time it progresses to dementia-like symptoms such as cognitive symptoms, difficulty in performing daily tasks, difficulty in retaining information, learning information. They may find themselves forgetful. They may find themselves difficult to find words to express themselves. They may find it hard to read and write, misplace items. They may even get lost in the neighborhood. They may even have, in severe cases, hallucinations, delusions. There can be motor symptoms, movement symptoms. There can be affective symptoms, which means mood symptoms as well, such as depression, agitation, disinhibition, apathy. So there can be a lot of different symptoms. So HIV causes a lot of different psychiatric symptoms, and we really, really have to look out for these. So I've so far talked about the biological symptoms, but there are a lot of different psychological and social challenges of HIV as well. So for psychological challenges, there can be worries of discrimination, which we talked about just now, a lot of self-stigma, self-blame. There can be a lot of guilt as well. So I encountered one person who blamed himself for getting HIV, blamed himself a lot. He said he's always been careful, but there was one time in the gay sauna he just let his guard slip, and then he got HIV, and he felt very sad, very guilty about that. And with all this background of discrimination, stigma, self-blame, that the person is understandably feeling hopeless, feeling helpless, and because of worries of discrimination, they don't want to seek help, which I will talk about in a minute too. So when they don't seek help, then and they feel helpless, they feel hopeless, and then the person may feel very depressed and suicidal. At the other end of the spectrum, again, there can be excessive health concerns as well. So I remember one case, not HIV, but HPV. So someone developed a tongue ulcer, and he basically was so convinced that he had too much oral sex when he was young, and therefore he had like tongue cancer as a result of HPV infection. So that's like the other end of that's excessive health concerns. So another issue, another psychological issue, another mental health challenge that people living with HIV may face is that because of their poor mental health in general, like they may have a lot of depression, anxiety, shame, guilt, they may find that it's hard to seek treatment. They may find it hard to adhere to the treatment even if they seek it. They may feel that, oh, there's no hope anyway, why am I taking pills? I might just as well let the disease progress. Some people may think that, so that could be another challenge as well. Apart from psychological challenges, there can be a lot of social challenges. So we talked about a lot of stigma, discrimination, and that really affects help-seeking behavior. They may feel that they don't want to seek help, therefore they have no social support. They don't dare to tell anyone that they have HIV, therefore they isolate themselves from the society. And then another issue to think about is spousal acceptance. Is the spouse going to accept the HIV diagnosis? Because I remember one person who, I'll talk about that later in the case. So, and also there are other social challenges include barriers to treatment. A lot of people don't even know how to seek treatment. So you can't just go to any GP on the streets to get HIV treatment, and people don't know how to get it because there are specialized centers in Hong Kong to offer HIV treatment. People don't know how to access it, and the cost of treatment as well. HIV treatment can be very expensive if you choose to go private, and privacy concerns as well. Some people are very terrified of letting people know of their HIV diagnosis, and therefore the HIV treatment provided by the government is really good on privacy. So in the hospital authority system, like in the computer system, you can't see any record from the HIV clinic. So privacy is really a double-edged sword. So when I talked about the 21-year-old man earlier who had HIV, so we just had no idea he had HIV because he was treated in Kowloon Bay and the hospital authority could not access that record. So we just had no idea he had HIV initially, and then he said he had HIV, so if he doesn't tell us he has HIV, then we wouldn't know. And then so I remember another case who was admitted to the psychiatric ward. He was confused and didn't know what was happening, so he couldn't tell us he had HIV. He couldn't tell us he was on HIV medication, so naturally, we didn't prescribe the HIV medication. A few days later, his mental state improved, and then he said he was on HIV medication, and then we were like, oh, okay, but the treatment was already interrupted by a few days. So this privacy has its pros and cons. And then, because of time, I'll skip through these special points to know. So I've mentioned that. So some HIV medication do have psychiatric side effects as well, such as depression, anxiety, and mania. So we have to pay attention to the iatrogenic side effects as well. And for local studies of people living with HIV, so I will just very, very quickly go through these because of time. So there are several studies that I know of that looked at MSM adults that were recruited from a specialist HIV clinic. So they looked at different mental health factors that affected like mood, anxiety, and general mental health in people living with HIV. So one study found that stigma really increased psychological distress. So stigma includes in-group stigma, meaning within the LGBT community, within the HIV community, there is a lot of stigma between the community members. There were also a lot of stigma, internalized stigma, and also stigma from outside the LGBT group as well. There is also zero status disclosure concerns, meaning they are really concerned about telling people that they have HIV. And also negative medication reminder is also a source of psychological distress. Negative medication reminder means that when they take medication every day, they are reminded of, oh, I have HIV, I am diseased, I am like ill, I did something bad, leading to this HIV infection, blah, blah, blah. So it reminds them of something negative every day. Another study also revealed that HIV, in people living with HIV, mental health is negatively impacted by similar stressors. Another study looked at a long-term relationship and mental health, and it found that having a positive love attitude, like relationship attitude, would have direct and indirect positive benefits on general mental health. So now I'd like to talk about the case I've been wanting to talk about. So it's a man in his 30s. So I actually encountered this man in Queen Elizabeth Hospital. And so I was asked to see this man because of, basically because of his refusal to see a doctor for HIV treatment. So he was found, I don't remember why he had some blood tests, but he had some blood tests in Queen Elizabeth Hospital, and he was found to have HIV several months ago, like 6-7 months ago. He was referred to the HIV clinic, but he refused to go. So I asked him why he didn't want to go. So he came up with various reasons. So he had low mood, he had a lot of anxiety, he had poor sleep, he ruminated about the HIV diagnosis, and he ruminated about, what am I going to do? What's my life going to be like? How am I going to tell my wife? So he had like a lot of mood issues, but he still but he refused to see a doctor for treatment. So even if Queen Elizabeth Hospital in the ward, they offered treatment to him, he refused. So that's why I was asked to see that guy. So I asked him, so have you really not told your wife? And he said, no, I haven't told your wife, but I haven't told my wife. But what about? So what did you do if your wife wanted sex? And he said he made various excuses not to have sex with his wife because he didn't want to infect his wife. But then he didn't want to tell his wife either. And then one thing that really distressed him was that he knew that his excuses wouldn't last. It's been 7 months already that he made excuses not to have sex with his wife. But the excuse is just, he's going to run out of excuses very soon. So that was really distressing for him that he had to tell his wife, and he didn't know what his wife would react. So that creates additional stresses. So there's biological stresses, there are psychological stresses and social stresses contributing to poor mental health. For the biological stresses, HIV may cause psychiatric symptoms directly. The psychological factors, the self-stigma causing him to not tell his wife, and social reasons, sociological factors causing poor health. He worries about how his wife will react, how people will discriminate him, and therefore all these contributes to poor mental health in this gentleman. So the take-home message is that mental health problems are very common in people living with HIV, and we really have to have a holistic appreciation of the emotional state in these individuals. We have to actively look out for mental health problems, and when we do encounter someone with HIV, perhaps with mental health challenges as well, we have to remember that we have to be professional, non-judgmental, and respectful. After all, we are treating an individual, we are interacting with an individual, with a person, and therefore we just have to be non-judgmental and respectful. We have to be empathic, try to understand what that person's feeling. We have to try to understand why that person's feeling this way, why this person's acting this way, and understand the presenting behavior and the presenting mood state. And we can try to help by increasing social support, maybe peer support groups or various NGOs for counseling. And if needed, we can also consider referring to a psychiatrist for management of mood problems or mental health challenges. And with that, I thank you for your attention. Thank you.